So we're very excited to have Dr. Cho, but in the interest of time, I will keep my introduction very short to maximize presentation with follow-up questions and discussion. So Dr. Cho, I'm sure a lot of you have heard of him. He's associate professor at UCSF Dermatology. Research is focused on single-cell RNA sequencing with an interest in understanding immunopathology. So really, this taking our technology and really bridging the gap and bringing us into the next decade of research, and now using fine tuning and understanding these pathologies with the interest, of course, down the line of improving therapeutics. So super exciting. And then Dr. Cho also has another arm of the lab focused on mutational analysis of skin cancers. But today's talk is entitled Molecularly Personalizing Approaches to Inflammatory Skin Disease. So thank you so much, Dr. Cho. The microphone is yours.
Thanks so much for having me. I just want to state my conflicts of interest, which are Sun and Leo Pharma grant support, also Sanofi and Regeneron. Thanks for introducing my talk. Really, thrilled to be here. I just want to, I was thinking about this talk, and I think most people training here have known, if you're in training, you've probably known of Rich Gallo for maybe 8 years at the most, but he's been doing this for so long and for so spectacularly. And for someone mid-career like myself, I think, Rich is distinguished from the outside as just being really, really straightforward and candid about what makes good and enduring science in ways that I think a lot of people of his stature are not. And so I've really enjoyed over the years my chances to interact with him, and it's definitely influenced the way I think about things. I also want to give a shout out to Matt and Robert. I know, there's exciting early stage work going on here, and I think there are a lot of people that are eagerly anticipating how that work is going to evolve. So you should know that. And I also wanted to give a shout out on the basic science side to George. And I think George's work has been so good for so long. I really think it's underappreciated. It's really cool. And if I'm sure he's presented it, but if any of you haven't seen his sulfate work, I think it was in Nature Communications from a couple years ago, just super, really, really good, credible, new work. So this whole department is, there's a huge amount of regard from the outside. And it was amazing, seeing part of that grand rounds. Those cases, again, were amazing. So my talk is about molecular analysis and how we think about inflammatory skin disease. But I'm actually going to start off with a slight detour. I had a dinner with an intern year friend of mine, 15 years ago now, and she's in maternal fetal medicine. So I wanted to share a story that kind of gobsmacked me. And she told me, first she told me something I knew, which is if you look at fetuses that are normal by trisomy screens or ultrasound, and you do chromosomal microarray like CGH, you find a chromosomal abnormality rate of on the order of about 1% to 2%. So that's known, right? And it's obviously going to reshape prenatal diagnostics in the future. But an Israeli group last year took fetuses that were also structurally normal, also had normal CGH, and did exome sequencing. And in this population, they found just unselected another 1% of pathogenic and likely pathogenic variants for moderate to severe disease, right? So if you add that up, that's passing 2% of fetuses that would normally be brought to conception without a second thought today. And she was saying that she thinks probably 5-7 years from now, that number is going to be closer to 5 to 6% carrying abnormalities because our rate of discovery of rare alleles is so rapid. And she went on to say she thinks in about 15 years, we're going to be like an IVF dominant society, because once that number reaches 5%, down screening, right? That all comers, that's about 0.1%. So once that number of concerning genetic abnormalities that you can detect prenatally reaches 5%, we're going to increasingly, in a first world sense, become very IVF driven, because so many parents are not going to want to take the risk. And I thought, that's crazy. Could that happen in my lifetime? That the natural, what we consider natural childbirth today, is just going to become almost bohemian, right? But when I thought about it some more, that's about right. About 15 years is the rate for dramatic change in medicine. I mean, if you live in a technology corridor like San Francisco or San Diego, I mean, change, like whether you're trying to change technology or commerce or dining or residence or transportation, I mean, it is so desired and thirsted after. I mean, we've come up with a useless word, disruption, for it, right? Because it spawns billion-dollar companies and people are so excited. But in medicine, if you've been practicing like I have now for more than 10, like 15 years, you see that's about the rate in which big changes happen in our field, right? And you really have to be here that long to understand that's how it goes. I mean, 15 years ago when I was finishing training, we'd be at drug dinners where the last generation was saying like, oh, I can't believe that we used to give methotrexate to psoriasis patients, adalimumab, this is like a revolution. And then now we're sitting in a place where we're in a maelstrom of IL-17 and IL-23 inhibitors, like biofunctional IL-17 inhibitors, first and second generation TYK2 inhibitors for atopic dermatitis, IL-4, IL-13, cyclic OX40. I mean, the number of options we have and the right way to choose them seems just completely overwhelming. And then if you look ahead 10 or 15 years, you can already see articles describing cell-based therapies like CAR T therapies for lupus and showing this recent paper here. Most likely, we're going to transition to a place where you can remodel the B and T cell repertoires to be able to treat inflammatory disease to approximate what patients think of as cures, right? So every 15 years, almost unbeknownst to us while we're busy doing other things, we see these big evolutions in what's happening in our field in dermatology and all of medicine. But what I actually want to talk to you about today is not the changes in treatment, which we have to grapple with on a daily basis, but it's the transitions in the way we think about diagnoses. When you're in a training program, you are armed with categories like psoriasis and atopic dermatitis and pityriasis rubra-pilaris or chronic actinic dermatitis, bullous pemphigoid. That's basically your toolbox that you hone. So you go out and you practice in the real world and you can basically understand what's going on with patients. But my argument and what I've seen over the past 10 years is if you're in major categories that have been defined, again, like atopic dermatitis and psoriasis by the NIH, by drug companies, by the FDA, I mean, the treatments have gotten incredibly sophisticated, right? In most cases, we have a really good first-line agent if the payers are going to cover it. When we try to get psoriasis and atopic dermatitis patients for trials in San Francisco, it's almost impossible to find someone who's not on like their second-line biologic. So it is really this in-between category, right? So not psoriasis, not atopic dermatitis, but, almost like, I mean, the grand rounds here, I think, is an exemplar of this. They're the cases that have clinical pathologically ambiguous features of multiple diseases that actually take up 80% of my time, and they have for several years, right? I mean, the obvious diseases, you already know what to do with them. So we bring them to grand rounds. They frustrate us when we go home, right? And in fact, this problem, even 4 years ago, was such a big deal to me that I started making a collection of patients that had rashes that didn't fit into simple category. Not all of them made it into grand round. So you're seeing 3 different patients here. And again, this was from really the beginning when we started doing this kind of single cell profiling. So these patients have relatively well-marginated erythematous scaly plaques. They look like partially treated psoriasis maybe, but have spongiotic features. And so I'm going to talk in a little detail about this patient on the right who was wheeled into my clinic probably about 4.5 years ago. He was an Asian male in his late 40s. And he had this very impressive presentation because other than having this generalized skin eruption, he also had this deformative arthritis. And as I'm sure many of you in this room would have done, I mean, one of the first things I said to him, this was my faculty practice, I said, has anyone ever told you that your skin and joint disease likely have some sort of relationship? And his answer was, oh, no, you know what? I've had this joint disease for 10 years, but I was just diagnosed as gout arthritis. So I'm on allopurinol and I don't, we don't need to worry about that. It's a skin disease. I'm using topical steroids, or I used to. It did absolutely no good. his copay for a biopsy was prohibitive. And so we had a long discussion. We looked at this. We thought that the plaques were relatively well marginated, and we were able to get adalimumab approved for him. And I think all of you here know that when you go to a world-class tertiary care center like UCSF or UCSD, and you have people look at you and prescribe you a biologic, the inevitable result is treatment failure, right? So this guy comes back 4 or 5 months later. He's actually redder and itchier than he was before. And the one difference in this case was he was willing we'd actually been able to adjust his insurance and get an authorization where we actually were able to obtain a biopsy. And this biopsy was taken not only for histopathologic analysis, which is what we wanted, but we're able to process it for, at that time, what was a relatively new single cell sequencing effort focused on CD45 positive immune cells. So we isolated these cells and we profiled them. As I'm sure anyone who does this work knows, the histopathology came back first and showed a spongiotic dermatitis. So frank spongiosis, even to a non-pathology trained eye like mine, vesicles. And I still remember thinking, wow, I can't even tell the difference between psoriasis and a chronic spongiotic dermatitis, So we put this patient on adalimumab. And as I mentioned earlier, the inevitable result when you get put on a therapeutic, and people are telling the story later, is that the patient had absolutely no response for 4 or 5 months later, right? So we're now about 10 months in with this patient. We'd really done him absolutely no good, spent a bunch of his and our money. The one thing that was really different about this case was that by the time he came back, we now accumulated enough single cell profiles that we could try to look at his data in the context of other data that we have. So what you're looking at here on the left, each one of these little clusters represents an individual patient in three-dimensional data space. And the individual dots represent skin resident memory T cells. So these are CD69, CD103 positive memory T cells that reside in and patrol healthy skin. So each one of these clusters represents an individual patient. And in blue, you have atopic dermatitis cases. In red, you have psoriasis cases. So these are individual patients. And you can see they segregate. This map on the left was performed using essentially whole transcriptomes, about 5,000 genes from individual patients. And then in orange, you see this indeterminate case we were struggling with, kind of sliding a little closer to the psoriasis part of the data spectrum. On the right, you can see the eventual data representation that we published, which focuses in on the 100 genes that most clearly distinguish psoriatic and atopic dermatitis T cells. And you can actually see this case really falls in the psoriasis part of the spectrum. And so when I saw this, I still remember when Jeff Chang is a colleague of mine, we work closely together, and I got this map from him, and I was thinking like, well, maybe this guy had psoriasis all along. I mean, we know that adalimumab has a pretty high failure rate in some patients, and this patient looked a little atypical. So we put this patient on tildrakizumab, an IL-23 inhibitor, and lo and behold, about 3 months later, these pictures were taken at his house. His skin had just beautifully cleared, right? And not only had his skin cleared, you can actually see the San Francisco Giants blanket in the background here for these photos that we positioned him for, but his joint disease had gotten better. So he lived alone in this big house, and he was shambling around. He was able to use a keyboard again. So he did have authentic gouty arthritis. That was just obvious from a clinical exam, but it turned out he clearly also had IL-23 driven joint disease. And the reason I like to lead with this particular case, and we have a few more that we're kind of preparing for these talks now, is it kind of illustrates why we're doing this work in the first place and why we're excited about it. It's really our belief that advancement of specific molecular paradigms can enable us as clinicians to be able to do better and thus to be able to do good, right? Because when you've been practicing, and I think anyone who's been in dermatology for, been actually in the clinics for 10 or 15 years out of training knows the things that make medicine so frustrating, I mean, it's not just the payers, it's not just Epic, it's there are very specific things. I mean, there's variable response to empiric medication. So you have treatment failures all the time, and you don't know if you've got the drug wrong or if you've got the disease wrong, right? If there's any ambiguity or vagueness. There are misleading clinical details like we had in this case. I mean, this patient had authentic gouty arthritis, but in preparing this report for publication, we had Kirsten Moorhead, a radiologist, review his radiographs, and it was clear that he had erosions representative of psoriatic disease, so coexisting psoriatic and gout arthritis, which some of you might know are, they correlate with each other. And then there's complex genetic pathology. I mean, we don't have time to think about this when we're going through a busy resident or faculty practice, but we know that psoriasis and atopic dermatitis cases, these are, they are convergent from many different types of genetic anomalies, and we're just seeing a spectrum. But I mean, how often do we have to actually think about where on the spectrum patients fall and how to quantify that? Really, really challenging. When we first started trying to solve this series of problems by having more molecular precision in how we think about inflammatory diseases, our thinking about this was really embarrassingly simple, right? It's like something your fourth grader would have come up with to present at a school report. This is actually a slide from an SID presentation I gave almost 5 years ago now. It's like you take a chronic rash that isn't getting any better, and then we're going to develop some kind of fancy molecular fingerprint, and then we're going to match it up against a library that is going to somehow magically cure that disease, right? And we were blessed not only with luck, which every clinician and basic scientist needs, but the reason we got as far as we did had to do with technology and the advent of single cell technologies. And I know the single cell work going on at UCSD, so I know you're familiar with it. But I just want to say, as someone who did a lot of work in cancer, I'll never say that cancer is a harder problem than skin disease. I don't think I could say that. But 10 years ago, you could take a tumor, you could puree it, you could do RNA-seq, even bulk RNA-seq, you could do exome sequencing, and you could get down to maybe a 0.5% allele frequency of an abnormality, right? You could figure out to a very, very strong first approximation what disease you were dealing with. But the kind of complexity that makes dermatology residency and the boards so onerous, right? You've got fibroblasts, keratinocytes, fat cells, T cells, Tregs, NK cells, like antigen producing cells. I mean, the huge cellular complexity of skin actually made that kind of analysis very, very limited in skin. I mean, you were basically mostly profiling keratinocytes when you're doing sophisticated RNA-seq for the past decade. And what single cell analysis basically allowed us to do is to focus in on specific cell populations and simply look at them versus normal, right? And if you're doing that, if you're simply looking at disease versus normal, you don't have to be savants. You can just be as smart as our lab. All of a sudden, the comparisons become highly, highly informative. For those of you who don't do this on a daily basis, you just take a regular skin biopsy like you do for H&E, but you have to keep it fresh. And in our experience, you have to dissociate overnight to get these cells out. And that's hard enough on the T cells that you really have to do the whole thing live before you flow sort and single cell emulsify these cells. So, I mean, we have patients, I go out to Fresno to find some of these patients, and I drive there at like 4 a.m. to get these samples, and I drive them back so we can process them in the same day. Once they go through the single cell separation process, you either count transcripts, sometimes epitopes if you tag them for each single cell. And this entire laborious, tedious process costs still about $4,000 a sample. And I remember seeing Rich at a meeting in Korea. I don't know if he remembers this, this before COVID, 2019. We were talking about this. And when we were talking about the prices, he said, "This is crazy. This is like far too expensive for the data you get." And you know what? He was absolutely right. We were incredibly lucky to get a bit of pharma support and a Leah Foundation grant to keep this going, because it was so incredibly expensive to get a data set where we could actually have numbers to figure anything out. So I consider him very, very prescient in that respect. So what do you get for all this labor and trouble? What do you get for, the greater than $1 million that we spent just getting here? So what you're looking at here in two-dimensional space are CD45 immune cells, each dot representing an individual cell. And these are, I think, about 15 atopic dermatitis, psoriasis, and healthy controls agglomerated together to show you the cell populations. Once you separate them out, you look at the transcriptional markers, and you can basically see every type of immune cell people have cared to publish on in the past 20 years. You see central memory T cells, Tregs, resident memory T cells, ILCs, NKs, mast cells, macrophages, different types of monocytes, Langerhans cells, like everything. You can actually see at really high resolution. And that allows you to make these comparisons. And we started off, obviously, we wanted to get to these ambiguous, challenging cases, but we started off looking at regular, pretty classic canonical disease categories. And we looked at psoriasis versus normal on the left here, atopic versus normal, healthy controls. And then we also looked at atopic dermatitis versus psoriasis. I think one belief we had is that historically people compare against healthy controls, but that brings a lot of nonspecific carrier inflammatory genes that have been described as quote unquote psoriasis or atopic dermatitis genes. So thinking as geneticists, it was important to kind of screen those out to get higher specificity. So we did a lot of work comparing the diseases together to figure out what was really central to the T cell pathology for individual diseases. On the y-axis, you're looking at all these different cell types that I told you about in the previous slide. And then along the x-axis, the number of genes that distinguish these different states. And I still remember looking at this slide for the first time and getting, a slight chill down my spine, because it turns out that the majority of the pathogenic signal will make these diseases different from healthy controls in each other reside in the skin resident memory T cells. And if you think about Rachel Clark and Liv Eidsmoe, who I consider kind of pioneers in this modern era, this field, they kind of figured this out 8 or 10 years ago without $4,000 patient profiles. We can kind of see it very beautifully in an unbiased sense now, but it really is here that all the action appears to reside. And it's interesting. And we think about PV and AD as just, they're just like our common currency, but they're very different diseases, right? I mean, psoriasis has this complex genetic and environmental evolution, whereas AD somehow gets programmed, at least in some important way, in the period of early life. The environmental influences seem to be larger, but somehow they both end up having a very, very large representation in the skin resident memory T cells in terms of molecular abnormality. If you're in inflammatory skin disease, people, Emma and Kruger, like there have been a lot of profiles where people have looked at psoriasis and atopic dermatitis in terms of RNA-seq. And the thing that's different about this work is we're looking really at the T cells, which have usually been underrepresented in molecular profiles just because they've been harder to isolate and profile in this way. So we generated a very specific suite of about 100 transcripts that describes the cell identity of these pathogenic T cells. So for example, here for atopic dermatitis specific, that particular transcriptomic signature, you can see not only in skin resident memory T cells, but also ILCs and other T cell populations. You can see very, very high expression in our validation cohort of atopic dermatitis samples, almost just completely quiet in psoriasis samples. And correspondingly, our psoriasis transcriptome is very poorly expressed in atopic dermatitis, with highly enriched in psoriasis. And even when we go to external data sets like Mosanipa's 2021 science paper, we can distinguish, again, the enrichment of atopic dermatitis and psoriasis genes in their skin resident memory T cells. And you can recapitulate these categories. You can tell that the psoriasis and atopic dermatitis samples are separate from each other, even if you weren't told what they were in the first place. Now, at least one of you in this room is thinking, that's like great. So you spent close to $1 million and you can tell atopic dermatitis and psoriasis apart, which, we can do walking in the room on most good days. So, I mean, really, what is the business end of this? And So what I'm showing you here on the left and right is kind of the evolution of our data set. On the left was our originally published data set showing a reference set of psoriasis samples in red here and a reference set of atopic dermatitis samples here in blue. You can see on the right now, we've almost tripled the data density. I think even since Rich might have seen this talk last year, where we have this very, very large number of psoriasis and atopic dermatitis samples. So we can start looking at heterogeneity within those data sets. We just had a JID paper talking about this methodology. But what I want you to focus on are these orange samples. So these orange samples are these clinico-pathologically ambiguous, difficult cases. And you can see that they really trace this beautiful spectrum between psoriasis samples, atopic dermatitis samples, and those obviously, the most parsimonious way of thinking about these is, you treat those with the respective biologic or targeted medication. But we also have a set of cases that really appear to have authentic Th2 and Th17 signals, at least by this way of categorizing disease. And, this really, there is a normal lower left-hand corner to this. So there really is something about these samples that's inflammatory on this spectrum that seems to draw from both activation of both cytokine pathways on the T cell level. So whether you're thinking about JAK inhibitors or OX40 or some other way to be able to inhibit both pathways, this kind of sets these apart clinically and in terms of treatment regimen. So we're investigating and working these series up for a publication. And we think this is going to be an important way of being able to think more broadly about spongiatic and psoriasiform disease as we go forward and use targeted medications. And just because I know this makes it seem like we're a psoriasis lab, but we're not. We're really kind of genomicists, and we look at Th2 disease too. So this was a 23-year-old who came in to our clinics around the same time, pretty early on, without a childhood history of eczema or atopy. Had these eroded, very, very itchy papules without a lot of intervening rash. Again, psoriasiform and spongiotic histopathology, responded very, very well to dupilumab. Actually, I just saw him this past year. It continues on dupilumab. That patient, I'm going to call that patient W, assorts really closely in the atopic dermatitis part of the spectrum. And you can see over here, patient X, who I started this talk with, falling in the psoriasis part of the spectrum. So we see patients on both sides of the spectrum when we're trying to sort out these unusual diseases. Another fair question is, do we really need multidimensional markers to be able to distinguish the spectrum? And my answer would be, well, I mean, maybe we don't to distinguish PV and AD. In fact, we're working with Jeff North, a histopathologist at dermatologist, I should say, at UCSF, to come up with specific stains. And we're looking at much cheaper, easier ways to be able to place patients along this spectrum, right? So all this really, really high resolution work may not be necessary to solve that problem. But what we're really trying to do is develop a more general framework for inflammatory disease, where you could take interface disease, lichenoid disease, granulomatous disease, look at these different immune cells, and really be able to place almost any troublesome rash on the map and understand how often multiple pathways collaborate to cause clinical disease. So we needed for that, we needed to decipher multi-pathway disease and to overall have a broader understanding of disease in the skin. And we also needed to understand drug response, which is where I'm gonna finish this talk. It is, I alluded to this earlier, and it is just a routine occurrence, and I would say an enriched occurrence when you're at a tertiary care center like we share, where patients don't respond to treatments. Because let's face it, you don't see the patients that respond to treatments. They come back once a year to get their note for reauthorizing their medications. So patients that fail that make up a lot of our clinics. And if you give a patient IL-23 blockade and they come back and they have a PASI 10, response, if they fail, before we started doing this work, I was just trying to figure out what else we could get approved for these patients. I didn't enjoy thinking about these patients. They frustrated me. But when a patient fails treatment, something goes on. When a patient fails IL-23 blockade, there is something molecularly that is happening. And I mean, it may be that their particular IL-23 inhibitor doesn't recognize IL-23 because the patient harbors a polymorphism. Or maybe that patient's genetic anomaly is somewhere in the receptor or downstream in the skin resident memory T cells, so they don't, they stay constitutively active. It may be that there's a keratinocyte difference in this patient, so that they're constitutively activated and inflamed at the level of the epidermis. So, something happens. We don't know what it is. We don't have time to think about it, but something is happening in this patient. And so to try to unravel this, about a year ago, we applied the skin resident memory T cell profiling to a series of IL-23 receiving patients in our clinic. So what you're looking at here on this diagram, each one of these circles represents an individual patient, an individual moderate to severe psoriasis patient that underwent IL-23 blockade with tildrakizumab and had a great response, like greater than PASI 75. They did well. They were thrilled. And what you're seeing on each one of these radar graphs, right? Each one of these spokes represents an individual transcript that is elevated in skin resident memory T cells of psoriatic patients. So this is the identity signature for pathogenicity and abnormality for psoriatic skin resident T cells. And the pre-state, when we profile before IL-23 blockade, is represented blue and normalized to each specific patient. So you see it's kind of blue along the outer rim here, as you would expect. And you can see for these patients that have a great response, these signatures shrink down and approach the center of the hub, right? So that the data really beautifully illustrates that on a molecular level, their T cells are getting cooled down by IL-23 blockade. Well, what do these skin resident memory T cells look like in patients who don't do as well? So if you have these patients with just like a 10 or 20% improvement, are their T cells active, or do they get quieted down? Is it the epidermis? It turns out in this early series that the answer appears to be that their T cells remain hot. So you can actually see in these poor responders, and they had a lower than PASI 50 response, you go from a very, very activated state, but you actually don't get that shrinkage or quenching nearly as much as you do in responders. So it really seems like a big failure of being able to get the pathogenicity contained in skin resident memory T cells. Well, after generating all this expensive data, we wanted to make sure, not only for these series, but be able to understand this in a personalized way going forward. Are we absolutely sure that in these patients that fail, that this is the sole problem? I mean, is it possible that IL-17 is coming from other cell populations, APCs or other T cell populations? So what you're looking at here is IL-17 production. This is mirrored for IL-17A and IL-26, showing IL-17F here. So in good responders to IL-23 blockade, to good responders to IL-17 blockade, you see these different cell populations, TRMs, APCs, NK cells, mast cells, and you could see that really more than 95% of the IL-17 production occurs in skin resident memory T cells, right? That's really where, as you would predict, the pathogenic cytokine is isolated. And then you go to mid-blockade. Again, these patients respond really well, and you've got more than about an order of magnitude reduction in pathogenic cytokine production. I mean, it's beautiful, gets turned off. So then we wanted to look at poor responders. Well, when you look at poor responders, you actually see a quite similar phenomena. There's not another cell population producing IL-17 that's driving this, not some hidden population. The majority of pathogenic cytokine comes from the skin resident memory T cell population. And when you go to mid blockade in these patients that don't do as well clinically, their T cells, as we saw earlier, are staying hot. So we really think that, at least in this early series, what we're looking at here is a fundamental failure of quieting down T cells. And, the way we think about this, it's obviously we're showing you this in aggregate, and, we submitted this for publication because it's our lifeblood and the coin of the realm. But, you can do this in individual patients, right? I mean, you can actually go to individual patients now. You don't have to do this in a series. We want to be able to take a patient that may or may not comport with the failures in this series. And if you need to, you can interrogate their pathway and figure out where the activity is. Where does the pathogenicity reside? And so in the most part, at least in this early series, it really seems kind of upstream here. But I do want to take a few minutes at the end here and talk about the keratinocytes, because obviously there's so much keratinocyte work. I think you guys do far more and better keratinocyte work here than we do at UCSF. We're very T-cell focused. So we used Visium technology, which is a spatial technology also produced by 10x that basically allows you to look at transcription of individual genes at 50 micron resolution. So you see an H&E and a staining of different markers here that segregate based on the skin layer. But what I want to draw your attention to here is this B panel, this little spoked wheel. Here you're looking again at genes. I think they're well familiar to this audience. These are genes that are upregulated in keratinocytes in response to IL-17. They're upregulated in keratinocytes in response to IL-17. So they're responsive in psoriatic skin. And what you're looking at this representation is on this 50 micron scale. As you get closer to pathogenic T cells, so the CD3 positive IL-17 expressing T cells, when you compute across an image like this, you can see beautifully, as you would expect, the closer you get to a pathogenic T cell, the higher the level of pathogenic keratinocyte response is, right? So you have the highest level of inflammatory keratinocyte gene response when you're close to a pathogenic skin resin memory T cells. As you'd expect, you've got in poor responders, you have a higher level of expression of these genes, and in strong IL-23 responders, that signal gets quenched down. But the point I want to make here that is interesting is when you look at this on individual samples, so each of these keratinocyte IL-17 response genes here, you're looking at on a different panel. You're looking at strong and poor responders, again, in blue and orange, pre-treatment in hatched, mid-treatment in clear. So what you're looking at in the red arrows right now, these are pre-treatment strong responders. Pre-treatment strong responders. And as you would expect, they have high expression of IL-17 driven keratinocyte genes. And then when you are treating them, when you go to mid-treatment, all those genes get turned off beautifully, as you would expect that skin to be normal. And again, Emma Gamiaski and Kruger's group, I mean, this has been shown through a variety of molecular methods that on the keratinocyte level, you can see this. But what I want to draw your attention to are poor responders. So it turns out in poor responders, again, you've got amplified, jacked signals for IL-17 responses you'd expect in psoriasis. But when you have poor responders, it isn't that those signals are staying on at 90% level like you might think when you look at a patient that's covered with red scaly plaques. It turns out you get 80–90% attenuation, at least on the keratinocyte molecular level, if you just want to count transcripts, but the patients are still clinically symptomatic. So there appears to be a nonlinear response between the keratinocyte molecular signal and how well these patients respond to drugs. So, that nonlinearity is really fascinating. It just indicates that a relative minority of the molecular signal can sustain disease. And it also points to why it is so valuable to be able to look at all these different cell populations, because it allows us to really understand the dynamic range of our inflammatory system. And again, going back to individual patients, I mean, series are one thing, but if you really are trying to sort out an individual patient, being able to look all these different ways at a single patient's skin is incredibly informative and valuable. At a high level, we call this project RASH-X. We've gotten to about 70 samples now, which is great, and we're hoping to get some NIH support for more. Our big questions in the next few years are how we generally approach these N-of-1 atypical rashes and make this diagnostic process simpler. I think we're very close to being able to flow sort these, so you don't have to make 10x a more valuable company, that you can actually do this much more simply to be able to put patients on the spectrum. We want to be able to understand how to circumvent drug resistance when we see that, and be able to understand where the drug resistance point is. And overall, we want to see how different classes of skin inflammation map onto a overall landscape. Where if you guys have genetic variants that lead to diseases, I mean, we're deep into studying a PRP family to understand how the different component, PRP CARD14 driven is in this family, is very, very different when you look at it molecularly in terms of drug resistance, because really CARD14 driving keratinocyte inflammation kind of short circuits your ability to be able to shut things off on the T cell level, which is something you see in clinical resistance. So we just want to understand what the overall landscape is so we can think about these diseases in a more sophisticated way. And there's a website called rashx.ucsf.edu where you can actually enter single cell CD45 data in and place patients on the spectrum between atopic dermatitis and psoriasis. But if you're interested in this at all, you can just email me directly. We can kind of work with your data and work you through this because it's something we're obviously invested and care about. So I'm just going to stop there. Thank you again for spending this time with me. My colleague Jeff Chen, we're equal partners in this. UCSF has been really great in letting us just be equal partners in a lab, which is something I highly recommend to basic scientists if it's possible to do. David Wu and Mark are graduate students that did this work. Elizabeth is the statistician who makes this happen, and Jae-Hyuk Choi is a collaborator with us at Northwestern. So thanks very much for your time.